Good morning, everybody. Oh, we can do better than that. Good morning, everybody. All right. Thank you for coming here today. Now, I know that the college represents what I would call a bell curve. There's a fragment of the college that's super excited about this. There's a large bulk who are inquisitive about it. And there's a few who feel maybe semi-degraded to be here today. Regardless of where you are in that bell curve, I can tell you that you will learn something today, probably lots of things, and I think you will find that it's a productive use of your time at the end of the day. We got the good fortune to have a conversation with Dr. Koch yesterday and a lecture last evening that she's going to kind of replicate to some degree today. And there's a lot of information in there about things which we don't usually have the opportunity to talk about in the College of Dental Medicine and in health sciences in general. So I think you will learn something. I'm absolutely positive of that, and it will be a useful day for you. I'm going to introduce Dr. Bertha Alarcon, and I want to let you know that she and Dr. Henson and others in the college have actually been working for over a year to get this scheduled. That's how popular Dr. Koch is and how diligent we've been working on this. And so I'm going to have Dr. Alarcon, who is our coordinator of diversity and inclusion in the college, introduce Dr. Koch. So again, thank you all for coming. I appreciate it, and have a good day.
Thank you.
Good morning. It is beyond words, the appreciation and thankfulness for everybody who has been involved to make this happen. Without Dr. Henson and Enriquez, Dr. Pape, and Dean Rowan, this could not have happened. And most important, the support and completely, continuously thinking outside the box of Dr. Dean Fredrickson. This could not have happened. So I'm forever grateful for the opportunity to have this very first conference on diversity and inclusion at Western University at large. Dr. Ann Koch received both her DMD and certificates of endodontics from the University of Pennsylvania. She's also the founder and past director of postdoctoral program in endodontics at the Harvard School of Dental Medicine. Following her clinical and academic career, Annie formed her own successful technology and development company, Real World Endo, of which she was CEO and president. Dr. Koch is the holder of multiple patents. The author of more than 150 articles in her specialty field, Dr. Koch has presented more than 1,000 lectures worldwide. She maintains a faculty position at Penn at the Department of Endodontics, as well as serving as a senior fellow with Penn Medicine. She's also a member of the Board of Overseers for the University of Pennsylvania School of Dental Medicine. Additionally, she maintains an adjunct faculty position at the Harvard School of Dental Medicine. She's an active member of the American Dental Association, the American Association of Endodontics, the Gay and Lesbian Medical Association, and the World Professional Association of Transgender Health. Without further ado, please welcome Dr. Koch.
Thank you. All right, thank you so much. Thank you. Thank you very much. I'm so thrilled to be here. And I'm really especially happy to be here right now because I'm speaking to so many of you who I have not had the good fortune of meeting in the last day and a half. So I'm so flattered by the warm reception, and you have a fabulous university out here. And you have to understand as students how unique and how special this is to have a dean and have a school being so supportive of this community that they bring somebody like me in to speak to people like you. I know there's a lot of publicity concerning transgender community and everything transgender, but as healthcare professionals, we have to be able to separate the misinformation, the good old-fashioned BS, from what's the reality and the truth. So what we're going to do today is we're going to talk about a couple of things. One is, and for the next hour, we're going to talk about curriculum changes. And curriculum changes are changes that you can input through your suggestions as a student, whether you're a first year or second year or a third year or fourth year. Also, faculty and staff can contribute their opinions and assumptions. Because what this is, what's so exciting, and you should be excited, is you're at the beginning of this. This is not something that you're adjusting to. This is something that you're creating. And it's much more exciting creating things because you can actually dictate the direction. You have to understand, for me, and we'll talk about it later when I do the Annie show, I had a very successful life as a guy. And now I'm kind of doing things and trying to rock it here as a woman. And that's great. But what I'm looking to do is I'm looking to educate people about all the different aspects of transgender medicine and the trans community. More specifically, really transgender medicine and dental medicine, because what I have now taken as my credo for the last 6 to 8 months is the following. We've gotten people's attention. Now we need to get it right. And so part of this is educating our providers, educating our staff. Another aspect is getting down and educating the patients. One of the things that you have to realize with these patients is that these patients are coming to see you. These patients also have had a horrible history in terms of relationships with the healthcare industry in North America. When you sit down and speak to trans people, you're going to be appalled at the stories they have, how they've been treated. As a healthcare provider, and I don't care whether you're a student, whether you're a doctor, whether you're a physician or a dentist, this is all about patient-based treatment. This is not about working with an individual, working with a patient and making a decision that's politically expedient. That's not your job. Your job is to do what's best for that patient, whether it's making a differentiation between a root canal and an implant, or whether it's having somebody go ahead and have a neovaginoplasty procedure or not having it. That decision is what's best for the patient. It's not what is politically expedient. So that's why it's really exciting for me to be with you today. It was exciting, tremendously exhilarating for me yesterday. What we're going to do here in the next hour is that up in New England, I live up in Massachusetts on Cape Cod, and that part of the country has been very, very involved with transgender individuals and the transgender community for many years. But one of the things that's so amazing, you cannot find any state more liberal than Massachusetts, yet this year they have a ballot to rescind all transgender rights in Massachusetts. Think about that. It's effing Massachusetts. It's not Mississippi or Alabama. That's a clinical term, okay? All right? And they have a ballot to rescind all transgender rights. And it gets into the bathroom thing and all that whole nonsense. So, you know, this is an issue that's completely misunderstood. And one of the things I do that's a little bit unique is I understand both perspectives. I have respect. Sometimes I'll be lecturing and a person will come up to me and they have carotid distension, nostrils flared, the exophthalmic, and they come up to me and say, you know, Annie, God doesn't make mistakes. My response always is, that's your opinion, okay? Not the opinion of most of the people in this room. And then they say something like, they almost invariably, they follow up, well, what are we going to have on medical history forms? Male, female, none of the above? And I say, no, how about male, female, gender non-conforming, and non-binary? And then they get really kind of crazy, and I just go, you know, have a cookie, okay? And then they walk away, and it's okay. But, you know, the thing is, I respect their opinion, but I don't agree with their opinion. Same holds on the opposite side with the transgender activists. You know, everyone's got to totally agree with everyone's thing. No, I'm looking for evidence-based research. I'm looking for decisions made by providers that are patient-oriented, not agenda-oriented. That's your charge. You know, I'm at the end of my career. You're all starting your career. That's why it's so important that at this point, kind of the nurturing aspect, you're making the foundation of your career and what you learn in dental school and medical schools with you for the next 40 years or more. So it's important to be here. It's important to be here with an open mind. It's important for you to ask questions. And trust me, you're looking at an individual and me, you can ask me any question you want, okay? You can ask me questions about transgender men, transgender women, medical practices, community. You can even ask me about the Red Sox bullpen, and I'll answer all the questions. So what I want to do here is that there's been some really active work done by universities up in New England, including Brown, University of Rhode Island, Boston, the Harvard Medical School, putting together kind of ideas for curriculums. And we have basically medical tracks and behavioral tracks. And they're trying to throw these out to providers and students and residents to see what is most important. Try to prioritize things so they can bundle it together into curriculums. I've been approached by TCU down in Dallas to do something very similar to this, to create a program that they can actually send out to different clinics, hospitals, and schools. Because these patients are coming in the doorway. And these patients need to be treated with the dignity and the respect that you should be treating all your patients with. No one is disposable, okay? So let's talk about some of these conditions and part of the curriculum. Aging and end-of-life care. Aging and the end-of-life care is a big issue for so many of all our patients, especially those of you on the medical side. But one of the things that's a problem is that, is anybody here familiar with LGBT elders and the horror story that goes on in some of these nursing homes? You take that one step further out to transgender people who've been disenfranchised from their family, and now they're being subjected to this humiliation and harassment in a managed care environment. That's so totally wrong. That's so totally wrong, especially to us as health care providers. So one of the things that you have to think about here when you're talking about having a curriculum put together, we're going to have to address aging end-of-life care. One of the things that's a concern to me with the transgender community, a little bit more so than the lesbian and gay community, is the unemployment rate. The bullshit in transgender information on the internet is stunning. I think the suicide rate is underreported. I think it's even a little bit higher than what they say, which is incredibly high. And I think the unemployment rate is incredibly high, especially for Black and brown individuals. And I've got news for you. If you're an attorney and you're a transgender person and you're working in CVS, that doesn't count. Okay? I'm sorry, excuse me. And I have enough of an attitude to have an argument. That does not count. So what we have to do is we have to find ways to have these people assimilate into society, be productive citizens. Also, on their side, they've got to understand and have to realize that, you know, just because someone is a cisgendered white guy doesn't mean that that's an enemy. That's not the case in the majority of cases. So there's room for improvement on both ends of the spectrum. But we really have to concern ourselves with employment issues, financial issues. I'm appalled at how many providers I know who are not transgender have very little resources coming to the end of their career. It's like, what the heck were you doing? I know some gentlemen, they've been through 3 or 4 divorces. They're 78 years old, they're still seeing patients. Why? Because they love dentistry so much? No, because they have no money. That's just the facts. So what I want, this is not a pleasant conversation, but I want us to understand the role that society and sociology plays with a lot of these individuals as they age. So the aging aspect, end-of-life care, maintenance in a managed care facility is something that we have to basically incorporate into any type of curriculum. Family planning, fertility, reproductive technology. I mentioned last night to the group, I purposely chose never to have any children. And the reason I chose never to have any children, it's not because I hate kids, I don't. But what I didn't want to do, I didn't want to be in a situation that if I had gone ahead, if I went ahead and changed gender, I didn't want to have a child who all of a sudden realized that their new mom was their dad, or their dad is now a woman. I have a lot of trans friends that have no problem with that. But to me, it was just my opinion. I didn't want to put that burden on a kid. I think it's very challenging being a junior high school boy or girl as it is. And I didn't feel comfortable putting that burden on a child. So I made a conscious decision not to have children. But many, many trans people, and it's absolutely a salient part of any curriculum, is that before people start hormones, right, especially testosterone or an estrogen and blockers, what are you going to do in terms of productive rights? This is also an issue with young trans kids and adolescents. So what we have now is we now have that ability for transgender women to basically bank sperm. And I know one transgender woman who used it 11 years later and had a surrogate deliver 2 kids, and she breastfed the children. So this is a transsexual woman breastfeeding her children, and that's easy to do. Basically taking a birth control pill and adding extra progesterone, okay? Also for trans guys, there's people now, a lot of female professional friends of mine, they're banking eggs. I'm sure a lot of you are already familiar with that. But these are reproductive options that have to be discussed with trans patients. Research updates and current research. This is a huge deal because up to now, most of the research, certainly out of North America, in transgender medicine has been consensus-based. Consensus-based with implied results doesn't work. Secondly, it's been a target-rich environment, meaning that there are a lot of studies like, well, I'm going to study the HIV rate among sex workers in Santiago, Chile. I understand that. It gets you out of Boston, gets you out of Philadelphia for 5 months. And you know what? You're going to get 4 or 5 papers out of that. But at the end of the day, it's kind of bullshit to me, pardon the expression. I want to see evidence-based studies that show 5 years out how many people have committed suicide, how many people have thought about committing suicide, what's the quality of life. 10 years out, how are people doing? That's the important things to me. What's the complication rates? You know, that's the kind of information, evidence-based, that we need to have. The good news is, as this whole field moves into the world of academic medical centers, research that's more, I want to say, I don't want to say it's more medically based, but let's just say it's more evidence-based and more important, in my opinion, research like that, that's going to come to fruition. People are gaming the system, both as patients as well as providers. As these young women and young guys come into transgender medicine, changing the game, there's less of these people interested in gaming the system. They are also looking for the truth. So I'm really sanguine about where this goes. It's going to be another 3 to 4 years where it's going to be fairly fluid, but good things will occur in transgender medicine. But research is also what brings the people who are hesitant to adapt this or adopt this as a legitimate aspect of medicine and dental medicine. Once you get evidence-based research, that changes. Preventive care considerations, that's a really tough thing to institute into a curriculum with transgender individuals. I think what that really does, that really leads more into the other one about caring for trans and gender nonconforming adolescents and children. Out here on the West Coast in LA, you are at the epicenter of that entire kind of study and kind of science with that. There are a certain couple of physicians out here who are really heavily involved with young kids and blockers and stuff like that. And at Boston Children's with Norm Spack and at Harvard, he took the model that came from the Netherlands. They've been doing this for years in the Netherlands in terms of blockers. But the difference is that Boston Children's Hospital and at Harvard, they on many occasions say no. Okay, it's not just a green light, they say no. Because one of the things that's really difficult with the blockers is that once people are on blockers, they don't go back to the original sex. So if somebody's starting blockers at a young age, it's a serious, serious decision, okay? In many cases, it absolutely is the right choice, and some other cases may not be the right choice. But whatever, it's a serious decision. Because once you start blockers, you're going down a different path. So we do need to talk about how do we do a proper diagnosis. If you said to me, Annie, what's the biggest problems you saw in transgender medicine in your experiences as a patient who's also happens to be a provider? 2 things. One, there was no follow-up. My apicoectomy patients have much better follow-up in my residence than I had undergoing such a life-changing procedure. Check clears, you're on your own, honey. And you call up, excuse me, I think my vagina's falling off. I'll go to the emergency room. That's not a proper response. I have a friend, she's a surgeon, and she's a woman like myself. And we were sitting one time talking at the Glamour meeting. The Glamour meeting is an acronym for Gay and Lesbian Medical Association. It's not just gay and lesbian providers, it's people working in the space. So probably about 60% of the attendees happen to be straight men and women, but they're working in the space. So I was speaking to this friend of mine, and she's a surgeon, and she had the procedure done, and she said, you know, Annie, for $34,000 cash, if I paid that to a practice in the straight world, I'd be getting a Christmas card a month for a year. She goes, I can't even get an effing phone call returned. And she's a surgeon. All right, those days are over. There's a couple still hanging in there, but that's changing. And this is good news because now, as we go through academic medical centers, as we go through the UCSFs and the Boston Universities and the Rutgers and places in Indiana, now we have follow-up built into this. So now we're making it circumferential. Now we're taking a holistic approach. I love osteopathic medical schools. Why do I love osteopathic medical schools? Well, a couple of reasons. I think osteopathic medical schools take really interesting applicants, okay? And also, I'm totally on board, especially for primary care docs and family practice docs, this concept of a humanistic, holistic approach. And I think that's what's so needed with a lot of the trans patients. Their diagnosis has to be better. And when you look at evidence-based stuff, the comorbidities with these patients is absolutely stunning. The comorbidity is high, and with young people, especially depression issues, anxiety disorders. You can get into this whole thing about autism, the whole autism spectrum, all that stuff. So I'm not here making political decisions. I have no political agenda. I'm looking for patient-based. And what we have to do is the medical side of the house has to improve their diagnostic capabilities with these patients. And it involves a whole bunch of things. It involves psychiatric medicine, involves therapy, involves endocrinology, involves primary care. It's a complicated issue, but it's an issue that needs to be addressed. Transforming medical and dental education. You're doing that right here. What this is that you have to have, and this is totally dependent upon the deans of the dental school or the medical school. I know one medical school in a part of the country that shall remain nameless because it's really an incredibly conservative state where they have one of the most progressive transgender medicine programs I know of. Why? Because there's a personal interest, okay? So what happens is that when people know people, you have a much different way of looking at this. And I said to some people last night, you know, for 35 years, I would go to dental conferences and people would come up to me, you know, Dr. Koch, do you have five minutes? Do you have 10 minutes? I said, yes. And they would always show me an x-ray. And invariably, these were cases that were involved in litigation. And they always wanted to have me give an opinion like, no, that root canal doesn't look too bad, right? Or no, there's another canal here that was missed. In the last 5 years, I don't have anybody asking me questions about endodontics at dental meetings anymore. Every time I go to a dental meeting now and somebody comes up to me and it's like, you know, listen to Annie, Dr. Koch, do you have 5 minutes? Of course, it's always about their nephew or their niece. So the questions now I get continually are transgender in nature. No one's asking me, am I short on the mesiobuccal canal? Okay? It's an endodontic joke, okay? So this is what we're doing. We're introducing it now into the schools. People like yourself, and it's a different generation, and it's a generation that's far more accepting to gender fluidity than my generation. I'm going to be 70 years old next year, okay? So I've been around, okay? I've been in this space for 45 years. So my generation, sometimes they have problems with the pronouns. They can't understand Z and they, okay? But the young people now that I see in medical school and dental school are the best ever in medicine and dentistry. And you people are coming in with an incredibly open mind concerning orientation and gender fluidity. That's a great start. But as you get this now, you have to take that wonderful foundation and you have to fine tune this to make this very appropriately patient-based, okay? Management of patients surrounding surgical care and innovations in care delivery. That's really not so much a dental issue. You know, there aren't too many dentists performing vaginoplasties or phalloplasties that I know of. If they are, that's a problem. But what the medical side has to do with this is that they have to institute better follow-up. And that's not happening. I know one doctor I went to had an amazing follow-up, and I talk about it in the book. I saw him to actually correct the original surgery. But what happened was that his office was so amazing, they would call once a week just to check in. And I finally had to tell the people in his office, you don't have to call me. I'm doing absolutely fabulous. But I make a notation in the book about this because it's so exemplary. This concern for the patient, that they're calling me just to make sure that I'm doing okay. And when you're dealing with these patients as a surgeon, it's not just about that the suture line is healing, it's about the mental aspect. As we get into academic mental centers driving this whole protocol of transgender medicine, follow-up and aftercare is coming along naturally. Prior to the academic medical centers, the best, most comprehensive care for transgender patients was at gender centers. And let me give you a little history on gender centers. When I say gender centers, I mean Callan Lord in New York City, Tom Waddell in San Francisco, Whitman Walker in DC, Fenway up in Boston, Mazzoni in Philadelphia. Between 1991 and 1998, I treated more HIV patients for endodontics and endodontic surgery than any endodontist on this planet. Can't speak for parallel universes, but I can speak for this one. I treated more than anybody else. There were huge issues with candidiasis with these people at the time, and we tried to avoid surgery. But those gender centers kind of petered out as new regimens came along in treatment of HIV patients. All the gender centers now in this country started out originally as gay men health centers, and they evolved and transformed into gender centers. They are often treating patients at or below the poverty level, yet they had the best continuity of care. The Fenway in Boston is world famous and it's amazing. But coming out of Boston, there's two things that we understand, anybody in healthcare. You want to make success in healthcare, there's two critical things that you need. You need infrastructure and you need funding, okay? So I'm going to talk about that with the entrepreneurial woman. That also applies to startups or any kind of business. You need infrastructure and you need funding. And because of that, what the Fenway's been able to do, it's been able to institute robust protocols. So what happens, people are following up. And it's not going to be the surgeon, the physician. It's going to be volunteers. It's going to be people working there on the staff positions. Hi, I'm calling from the Fenway. How are you doing? Is everything okay? Great. And just a couple of simple questions. It's like for me, I've never done a root canal in my life, surgically and non-surgically. And the vast majority of my residents have never done a root canal procedure, endodontic procedure, without calling the patient in the evening. It's 45 seconds. Hi, this is Dr. Koch. I'm just calling. How are you doing? They're stunned. They think I'm asking for money. That doesn't, I have no interest. All I want to know is how you're doing. If you have any issues, we're here for you. If I've written a script, and especially for women, women are terrible about getting scripts filled because they got to pick up Timmy from soccer practice. They've got to pick Janet up from cheerleading. I'll get it filled tomorrow. If I wanted to have you get it tomorrow, I would have told you to get it filled tomorrow. So I started having my female patients taking antibiotics in the office, right? But when I'm calling for that 45-second conversation, what I'm doing, I'm creating a relationship with that patient. I want them to understand that I care. When I treated patients, you can't do this on the medical side, but in endodontic and dental side, you can. I gave them my number. In all my years of actively treating patients, I had 2 people call me at home, and they were incredibly apologetic. The service screwed things up. But what I want, and what I firmly believe in, is I care. I care about your health, and I care about you as a person. And again, we need to take that and extend that into the treatment of patients, however they may present and whatever they may present as. Also, in terms of sexual health, sexuality, and pleasure, I think that's a topic all of us can find some enjoyment in. And I think this is very important. But one of the things I talk about in my book is that this has been also an area in transgender medicine that's been heavily BS'd. Okay? Let me just give you the facts, okay? Just the facts, nothing but the facts. A natal woman's clitoris has, keyword, exponentially more nerve endings than the glans penis. And when surgeons do a vaginoplasty procedure, what they do is they take the glans penis and they dramatically reduce the size of it. Maybe it's like 99% reduction to create the new neoclitoris. Yes, okay, it's now a neoclitoris, but it's a clitoris with a lot less sensitivity, okay? That's the facts. So the sexual satisfaction afterwards, especially for an older individual, is a challenge. Is it impossible? No, it's not impossible, but you gotta find different ways. And having sexual enjoyment as a woman over 55 years old is very different than a guy over 55 years old, right? It's much easier for people younger than people on the opposite end of the age spectrum. In terms of kids, let me tell you something about trans kids on blockers. Well, what happens a lot of times with these kids on blockers, you know, there's a question about how much will the testes descend, and the kids end up with a little microphallus. So now if they come up to be 16 years old and they're scheduled for a vaginoplasty, they don't have enough material to work with. So what happens, generally the physicians take expanders and they put them in the abdomen, and that's where they get the tissue to graft. But there's another aspect here too. These kids really haven't had any enjoyment sexually as a boy, and now they're being in a position as a trans girl where it ain't so easy, right? This doesn't mean that they shouldn't have the procedure. It doesn't mean that it's a death, you know, star for that procedure. All I'm interested in is the facts. I want people to be fully informed. I want people to be fully informed about the positive aspects as well as the negative aspects. I want people to understand the good things that may happen. I want them to understand some of the challenges they may face. This is about proper informed consent, okay? This next one here about intersections of identity, oppression, multicultural experiences. That I think is not just related to trans, that's related to a lot of our patients. In terms about surgical options and updates, that's not so much in the dental curriculum, but I think the one that is going to be involved more with us as dentists is about behavioral health needs and trans care. One of the things you have to realize is that taking hormones affects people differently, okay? Testosterone is an incredibly powerful hormone. Testosterone also, some of these people can have some advanced perioral disease. You also have some of these situations where it's not just some skin care issues. There are some trans guys who think smoking makes them look macho. So now you get back into the smoking issue. For estrogen, people taking estrogen, there have been some studies about having an effect on the TMJ. That's kind of moot. But if somebody's taking progesterone in combination with the estrogen, which is not that common, that makes that individual very susceptible to a pregnancy tumor, which the proper name is what, dental students? Like pyogenic granuloma? Okay, hello, okay. Hello. So this is what we want to have here. You have to be aware when you're doing your medical history, the meds that they're taking, and treating them like any other patient. Yes. Yeah, I mean, Lupron is a really, really powerful thing. And there's all kinds of questions about blockers in terms of long bone growth and other things like that. But in terms of the dental thing, it's really not, I don't see a lot of effects in terms of the dental aspect of that. Right. The concerns with the blockers are more on the medical side rather than on the dental side.
And one other question, I had a patient when I was in practice who was a male patient and then went through his sexual transformation to be a female. And I really didn't know, I was inadequate. I felt inadequate when he asked me some questions about whether he should be have prophylactic antibiotics after having just had the surgery and things like that. So I really felt inadequately prepared as a clinician to make sure I was observant of what might be a side effect. So I think that might be a piece of what we should understand as clinicians and what we should put into our curricula is, are there certain considerations we should be looking at in the health history and for side effects?
Well, you just touched on the point, comprehensive health history. What's one of the problems with trans people? They lie. Like all of us lie, right? But the reason I'm saying some trans people is that they've been so traumatized by past experiences. One of the problems has been is, people will go to a doctor for years and they're a trans guy, and you have to understand 99% of transgender guys have nothing done below the waist. They may have had a double mastectomy, they may be taking testosterone, but below the waist they're a natal female. All of a sudden you've gone this long without having a pap smear. All of a sudden, what's the diagnosis down there? How come you're getting cervical pain? Where is that coming from? I actually happen to be a natal woman. These are issues, and the only way this comes out is by creating a welcoming environment. If I was a person who had been harangued and humiliated, I'd be really hesitant about sharing things too. I could also tell you on the older male to female, people will stop going to see doctors because they've shaved their hair. This is very common with men 40 to something years old. If they're living a life where they're living part-time or sometime as a woman, and if they're shaving their hair, they avoid going to see the doctor. They're so worried that the doctor's going to say, oh my God, you have no chest hair, you have no body hair, what's going on? That's not going to change until we as providers have them understand that we're not making a value judgment. Well, we're looking for your health. So in terms of the ramifications of having surgery, there's no need to take preoperative antibiotics because you had a vaginoplasty, okay? But the point that you're making that is salient is that we need to be able to ensure that we're getting a comprehensive medical history from these people that's taken in a respectful way. That's the key, okay? Substance use and recovery. This is an issue with so many patients. My thing again here is, especially with young, and this gets into the Black and brown community big time in the cities. We have too many young trans women. They don't have an educational background. It's pretty easy to get 850 Mentor implants in certain states on Medicaid. Next thing you know, they're working in the sex industry. That's not a long-term job opportunity. And my concern is that no one seems to be having an honest conversation. It's more about, is there insurance coverage? How can you get the 850s free? Wait a second. That's not the story here. How can you change your life to be a productive citizen? If you can get the 850 implants, great. And you can get back to school, get a job, get your body, get clean, get sober. These are really more salient issues. Again, this is why it's patient-based rather than agenda-oriented. But substance abuse and recovery is an issue. Also, not so much for us as dentists, but on the medical side, HIV PrEP being abused also is an issue. HIV PrEP is such a great thing if you've treated AIDS patients. It's not meant for you to have a crazy lifestyle. It's meant to help people and to be a cushion, not so that you can have a wild and crazy life. Spirituality, obviously that works for all kinds of different patients. Violence about trans populations. I just made a donation, Massachusetts, for the Transgender Day of Remembrance, Transgender Day of Remembrance, TDOR. So I gave them $1,000. And the reason it is because the violence still continues. And it's just so wrong. Violence against anybody is wrong, but the transgender population really seem to be susceptible. Also, one of the problems here is that if you don't have the education, if you don't have a job, if someone is not speaking to you honestly enough and saying, listen, Josephine, yeah, girl, you got to get yourself a job. You got to get yourself sober. If no one's willing to have these conversations, it's too easy to fall into the whole mystery of abuse, fall into the thing where you're basically joining customers and working in the sex industry. We have to have a better way of working with these people. And interpersonal violence, one of the things that we see too often with young people is cutting. Have any of you had patients that come in, young adolescents who have been cutting themselves? It's stunning at how many people are cutting themselves. One of the things that's a concern to me is that there are websites geared to young people telling them how to have their parents accede to their wishes. You know, the whole story about what would you rather have, you know, a dead daughter or a happy son. And there's even websites instructing people how to cut themselves, not too deeply, but by cutting themselves to be able to get permission to start testosterone or to start blockers. So we have to be a little bit smart about that type of self-aggression behavior on some people. Yay, looks pretty good to me. Thank you. Oops. Unpacking cisgender privilege and basically family therapy or trans and non-binary adolescents. This is such a huge issue, I think, for medical schools and dental schools as well. Obviously, there's been an explosion with gender non-conforming kids, you know, less than 18. Obviously, it's been heavily publicized. People have very strong opinions. For me, one of the things I love the idea of gender being a spectrum. I love the idea of that, you know what, if you're a little bit effeminate as a guy, it's totally okay. If you're really kind of butch as a young woman, it's absolutely fine. I love the idea of people finding themselves, because what people don't seem to realize, and it's obvious to me, what may work for you at age 16 may not work for you at age 20, and neither of them may work for you at age 25. So this idea that you've got to make a rigid decision at age 14, I don't agree with. And people who change their level of transitioning, you know, they're being a little bit less feminine, they're being a little bit less butch. That's their own personal decision. Support those people. I really take umbrage at this thing about you want to pigeonhole people into this, this, or that. I love this concept that your generation has fostered about gender being a continuum and being fluid. I think gender fluidity has so many positives to it. Support people, love people for what they are. Cisgender providers working with trans, gender nonconforming patients, unpacking cisgender privilege. I take, of course, tremendous exception to that, okay? Because I know a lot of cisgendered people of all different colors who are incredibly, incredibly dedicated, okay? So to me, to just say, well, this group of people is the arch enemy of that group, it's wrong. What do you want to do? I went to college in the 60s, and the 60s was an era of tolerance. And I understand people being really passionate about their viewpoints. I understand people on the extreme right, they're passionate how they feel. I understand people on the far left, transgender, activists, anarchists, how they feel. I respect their passion, and I appreciate that. But I also want to have them people understand the way we accomplish change, the way we accomplish permanent change is by establishing dialogues and having tolerance, okay? So what I mean by that is, like, I consider myself a 35-yard politician. Did you ever hear that term? 35-yard politician? That means I think everything is accomplished between one 35-yard line and the other 35-yard line. And I can talk about yard lines because I was a quarterback in high school and in college, okay? So that's how you start a dialogue. Respect your neighbor, respect your colleague. Then you have a dialogue and do something constructive. So to me, just because somebody is cisgendered or somebody is this nationality or that nationality doesn't mean they're an antagonist. Eating disorders, to me, I had a section in my book that I edited out. Not my editor, I edited out because I realized I'm going to get completely trashed because I could not say it in a book without getting trashed. I have an enormous concern. And when I speak to the transgender surgeons, the people performing these surgeries, I've asked a number of them, You see some of your post-operative trans people have issues with obesity, like 50 pounds, and they generally say 50 pounds. I say, oh, 100 pounds? More than 200 pounds. Have you ever noticed how many post-operative trans people are really, really borderline, if not morbidly obese? What's going on here? Is it the sudden reduction of testosterone that's generating this? Is this a personal unhappiness? I don't have the answer. The only thing I can tell you, it's a medical issue that needs to be addressed, okay? Two things in transgender medicine. We need to have better surgical procedures for trans men. Phalloplasty leaves a lot to be desired. And we have to address this sudden and incredible weight gain by post-operative trans women, okay? It's not just an image thing, it's a health issue. But it's very, very tough in the current climate to even broach a subject like that without getting completely trashed. Public health for both medical schools and dental schools, but more on the medical side, is really an issue. And I think one of the things is the public health story for transgender medicine and transgender dental medicine, much less than medicine, really goes through a lot of the gender centers. They have really orchestrated a lot of the themes in this country, everything from informed consents with certain patients to actually having effective follow-ups. So what we have to have, and we will see in the future, we will see more of a public health advocacy. Ethical research to me is a big issue, and that really translates to me, not just ethical research, evidence-based research. And you can't quelch research if you're an institution because it's not matching what you wanted it to be. That's a game, that's entertainment, okay? If you're doing research, we want to have research that's going to let us know, what we're dealing with. Gaps in research and literature. This has been a problem that I think as we go forward, right now because of this case up in Brown, that became a civil rights issue, that became an academic integrity issue. That's not going away. Because anybody who's working in a medical and dental school is a faculty member, especially full-time faculty members. There's a certain amount of academic integrity and protection that you insist on and you expect. And so to have a school cave into a social movement is not right for any issue. The truth is with young kids, there are a lot of young kids where taking blockers and then eventually hormones and even eventually surgery is absolutely the right decision. But there's also a number of kids where it is social contagion, where it becomes trendiness. You just can't get red-faced and carotid distended yelling at each other. What you have to understand is that there's legitimacy here on both sides. How can we work together to get it right the vast majority of the time? That's the issue, okay? And then eating disorders is another thing. It's interesting because people are linking kind of the eating disorders now to this great demand by young girls to start testosterone and things like that. I would rather just keep eating disorders by itself as eating disorders. Here's the problem with eating disorders. Not so much anorexia. Yeah, there may be some young trans girls, 15, 16 years old, who are really, model thin. But usually the eating disorder with young adolescents in the transgender world goes the opposite. It's a weight gain. Why? Well, for a young transgender girl, if they gain a lot of weight, they may have the illusion of having breasts, okay? Hoping to have almost like gynecomastia. But the breast development will give them a little bit more of a feminine feeling. On the other hand, some trans guys, young women natally, they might gain weight because it obscures the breasts. So the breasts are not as noticeable. I mean, this whole thing about young trans guys wearing binders, I mean, how uncomfortable is that? So there's a myriad of issues here involved with putting together a curriculum. So for me, when I see all these different aspects, to me what this is about, this is a little bit different in medical school and dental school. For dental school, this gets back to the question previously asked. This gets back to how can we treat these patients within the realm of our specialty, meaning dental medicine, in a way that's safe and predictable and patient-oriented. That is firstly and foremost, not the diagnosis, because the diagnosis is made by somebody else, not a dentist. But what it is, it's having a comprehensive medical history. We've got to understand where you've come from, where you're going, what are you taking, okay? After that, for us as dentists, treating transgender patients as dentists is really pretty easy. You know, class 3 resin on a straight person is no different than a class 3 resin on a lesbian, gay, or trans person. It's a class 3 resin. What separates you and what's going to separate you as an outstanding clinician going forward is not how good your class 3 resin is on that person. It's how you treat that person. That's where it's different. So if you're a dental hygienist or if you're a dentist, it's going to be not about the care per se, because that's no different. What it is, it's going to be how you create a welcoming environment for that patient. So as schools build curriculum, and I don't know what you're going to be doing at Western here, but if you're building a curriculum, these are all aspects that I think you probably can incorporate into the mix. And then you probably, you know, kind of precipitate out the key areas of a curriculum that you feel will address your goals most effectively. Questions? Comments? Yes.
The issue of not having follow-up, the idea that there's not necessarily follow-up after a procedure, I think this is a general problem in medicine today. It's not necessarily related just to transgender issues. I know in my own case, I've had a couple major surgeries in the last 2 years, and I've never had anyone call me ever to see how I was doing, and I actually didn't expect it. So, I mean, I'd just like to make that point.
I think your point there is not only well taken, but I think it's very much real. There's one difference. And listen to what I'm going to say here. Other than dying, the most personal thing that any person can do on this planet is changing one's gender below the waist. It is different. Okay, that's my point, okay? And I even talk about it in the book. If you're a surgeon and you're performing vaginoplasties and you don't want to be emotionally there for your patient, take out gallbladders, okay? This is an incredibly profound change in a person's life. Death is the most personal thing any of us will face. But the second most personal thing is changing one's gender. You're absolutely right. Continuity of care doesn't exist in many parts of medicine. It does exist in dentistry, thank God, as we know. Also, you can have procedures and you never hear again. You see the nurses' follow-ups. I understand that. What I'm trying to do is I want people to understand what a profound change this is. Just because people now have access to the procedures through parents' insurance or their insurance they get with their place of employment, doesn't mean it's a cavalier decision. This is an incredibly significant decision, and that's what I mean. And again, what I have seen with these people, it's not just a matter of like, thank God I survived the procedure. This is going into a whole new world. One of the biggest mistakes is that people undergo a gender reassignment procedure and they see it as an endpoint. It's just the opposite. It's not the endpoint, it's the beginning. It's the beginning of your new life, be it as a transgender woman or a transgender guy. It's not an endpoint, it's the beginning. And in my book, I use dental analogies. And for instance, like in plastic surgery, you really have to have some maintenance. If you're an older individual and you have some plastic surgery done, you have to maintain your skin, else you're going to lose the results. And I liken it to periodontal therapy. If you have periodontal therapy, but then you don't floss and brush, you know, a year and a half later, you're back with 4, 5, 6 millimeter pockets. So what I'm trying to do is I'm trying to make the case. The reason that follow-up is so important to me is I've seen how people go off the table. Okay, you have some kind of procedure done, whether it's a procedure done in the gut or some kind of shoulder orthopedic procedure done. You're recovering and you're doing physical therapy. You're looking to get back in your life. But when you have a vaginoplasty done, it's not just healing from the sutures and from the incisions. It's taking this within the context of such a profound change. Okay? But you're absolutely right. The follow-up across the board is not good. Yes?
I'm just curious as far as these are all amazing topics that I think should be included in any curriculum, but I'm curious as to how do we do that? Where does it fit? And where do you see success so far in implementing these across the curriculum?
In terms of a transgender curriculum?
Well, yeah, just how do we incorporate these topics in a global sense?
Okay. In terms of, it's not going to be a global sense at all unless major institutions start to get on board with it. I will tell you, Harvard Medical School has gone above and beyond now in terms of LGBT courses. They're making a serious effort. They're doing it in conjunction with the Fenway. Have they gone to a specific transgender curriculum? No, but transgender medicine is a very strong component of the LGBT thing. They actually now have electives and they actually have other courses. So as medical schools start to bring this in as an obligatory function, because the biggest concern is producing providers who've never worked with this patient population. And then the most common thing that happens out in the world on the primary care or family practice doc, trans person comes in and they get booted out of the office. Well, this is specialty work. In reality, working as a primary care doc in transgender medicine is easy peasy. It's blood panels and the administration of hormones. Easy peasy. But what happens, they just feel uncomfortable and it's an easy excuse. It's specialty work. As more and more people are coming out in medical schools addressing this issue is now people realize we have to have all our students and residents have experience working with the people. They don't have to go into transgender medicine, but they have to know how to respond. For instance, with OBGYN programs, they realize, oh my God, we're seeing a lot of patients with neovaginas. How are our residents going to treat these people properly and appropriately? So again, this is just about awareness, but where this starts, God forbid it starts in the internet, it's going to have to start first in healthcare institutions, principally medical schools. Yes.
Yes, I would like to ask a question. In a situation where a non-binary restroom is available, how do we appropriately and also respectfully address a person whose appearance may not be obvious to their own person's gender identity? And yet, we also need to differentiate between people who may take advantage of the opportunity and be sexual predators.
Yeah, I don't agree with the sexual predator thing. That's a thing. In Massachusetts, we've had a bathroom law and they've had not one case. I think the bathroom thing has been used as an excuse to try to prevent transgender people from having access to bathrooms, okay? That's people's right. That's people have their own opinion on stuff like that. You know, I lived for 8 years in Japan. I lived, for a year in Korea, but 8 years in Japan. The bathroom issue is a non-event outside of the States. It's kind of like, everybody uses kind of the same bathroom. So for me, in the States here, obviously, here's where the problem that happens is that no one, I think in most states, have a problem with somebody who is living as their affirmed gender if they're reasonable. Where it gets into problems is the extremes. It's just like competing as an athlete in the opposite gender. If somebody looks like a woman and acts like a woman and competes as a woman, there's generally not a bunch of resistance. But if somebody kind of looks like a guy, acts like a guy, and behaves like a guy, that creates a lot of animosity with the other female athletes.
Yeah.
So for me, I am all for having a bathroom of your affirmed gender. What I'm trying to make a case for, people who are transgender, so to have those people, I killed the lavalier.
You talked it to death.
I talked it to death, literally. For me, is that they have to be reasonable in their presentation as well. Okay?
Thank you very much.
Thank you. I think we're at a breaking point now, right? To switch to the entrepreneurial portion of the program. Let's thank Dr. Koch.